Over to Dr. Sujita.
So you're not audible, Dr. Dutt?
Maybe your audio has to be put on.
Hello, am I still audible?
Can you hear us? No, now you're audible. Yeah.
Yeah, thank you so much. Yeah, at the very outset, apologies for this technical glitch. At the very outset, let me take this opportunity to thank Dr. Datta and the entire organizing team of PGI Chandigarh to giving me this opportunity to talk on antibiotics and pancreatitic infection. A disclaimer, I'm a gastroenterologist with very little knowledge on antibiotics. So I will just start off with where we encounter the role of antibiotics in GI practice, and the two common areas we commonly find challenges with is in acute pancreatitis and acute cholangitis. I'll start off with a brief case discussion. A 52-year-old lady was admitted with us with acute pancreatitis, which was gallstone related. She was referred from another hospital and admitted there for 25 days with acute pancreatitis, gallstone related, acute lung injury requiring mechanical ventilation. On admission, she had ongoing pain, high-grade fever, and features of SIRS. We started her on broad-spectrum antibiotics, but she did not show any signs of improvement. Later on, we went and proceeded with the CT-guided FNAC. We showed Klebsiella, which was a carbapenem-resistant organism, along with Pseudomonas aeruginosa. Both of them were only sensitive to colistin. Required the placement of drains, multiple drain repositioning. Luckily, we were able to salvage her after 3 weeks of intensive care. Infections in acute pancreatitis start off very early on than we expect, actually. And this is a post-hoc analysis of the ProPatria trial. The ProPatria trial was the trial which investigated the role of probiotics in acute pancreatitis. And this is a large trial from the Dutch acute pancreatitis group, a large study, which was around 730 patients. As you can see, the initial infectious complication almost starts off as early as 8 days. And the initial infections are usually pneumonia, bacteremia, followed by infected necrosis. And if you look at the timeline of this, initial days, this pneumonia, bacteremia, but as we enter second week, infected necrosis starts to play a major role in the infected complications. And the nature of bacteria that is encountered includes both gram-negative and gram-positive bacteria. Obviously, gram-negative bacteria is the predominant for, including both E. coli, Klebsiella. The gram-positives include Staph aureus, Enterococci, Strep aureus. But more importantly, a sizable number do also have fungal infections, and with fungal infections, the mortality is much higher than that encountered with other pathogens. So this study also showed that one of the important predictors of death is the presence of bacteremia. So infections in acute pancreatitis is a predictor of mortality. And what is the source of infection? As we were listening to Dr. Saraya's talk in the past a few minutes, where he was alluding to the gut barrier dysfunction and the role of early enteral nutrition, gut barrier dysfunction plays a significant role in the infection in acute pancreatitis. And this has been proven time and again. And this is another study which showed that gut barrier dysfunction is present 3 out of 5 patients with acute pancreatitis, and this is not affected by the severity of the disease. So is there a role for antibiotic prophylaxis in this group of individuals? I've just summarized the data from 3 important meta-analyses which have happened over the last 10 years. The first was a Cochrane meta-analysis of 7 randomized controlled trials, including 404 patients. The outcomes was no benefit in prevention of infection, no mortality benefit. The group of RCTs, which included imipenem, showed a reduction in infection, but no benefit in mortality. This was from the Japanese group of investigators from the Japanese pancreatitis study group, and this included 6 studies, and most of the studies used imipenem. The studies had a total of 397 patients. What this meta-analysis showed that antibiotic administered within 72 hours of onset of symptoms reduced mortality and reduced infection. Now, this was a bit of a variance from all the other meta-analysis. In fact, the last meta-analysis which came in from the Chinese group, which included this 6 plus the previous meta-analysis, a total of 11 randomized controlled trials, 747 patients, did not show any benefit in prevention of infection necrosis, no mortality benefit, but did show a significant reduction in non-pancreatic infection. Therefore, what we can see, the jury is still out, and this is amply shown in the guidelines that we have as of now. If you look at the IAP and the APA guidelines, routine antibiotic prophylaxis is not recommended. The ACG guidelines not recommended even in severe predictive. The Italian guidelines say routine antibiotic prophylaxis is not recommended. In pancreatic necrosis involving more than 50% of the cases, antibiotic prophylaxis might be considered on a case-to-case basis due to the high risk of infection. A lot of ambivalence in the guidelines. The AJ 2018 recommendation says not recommended. However, it is the Japanese guidelines which instituted that particular meta-analysis, which goes on to recommend that there may be a role of antibiotic prophylaxis if it is carried out very in the early phase of pancreatitis. So I would say the jury, as regards antibiotic prophylaxis in acute pancreatitis is concerned, it's still out. So when we suspect infections, what are the features? The features are when the patient has persistent SIRS, clinical instability, rising WBC counts, failure to improve after 7 to 10 days of hospitalization. Is at that point that we have suspicions of infections. And that suspicion is further, we can investigate with procalcitonin, CRP, hematocrit, ECT, we include a CT thorax in suspected pneumonia. And if we find gas within the infected necrosis, it's probably a sure sign of infection. We obtain cultures from blood, urine, aspirate, acidic, pleural fluid, anything that can give us a clue as to the bug that we are dealing with. I'm just alluding to procalcitonin a little bit because this is something we rely on very much at our institute back in Vellore. And overall, in acute pancreatitis, procalcitonin has been shown to have a very high sensitivity and specificity for predicting the presence of an infected or the development of an infected pancreatic necrosis. This is a meta-analysis of 17 studies. 17 studies with 329 patients. Sensitivity was 80%, but specificity was 91%. So if there is a culture positive bug, culture positive acute pancreatitis, what it shows is that in those group of individuals, there's a higher risk, a higher incidence of endoscopic necrostectomies, the number of procedures are more, length of hospital stay is more, ICU admissions is more, in-hospital mortality is more, 30-day mortality is more, 1 year overall cause mortality is higher, antibiotic administration obviously is higher. So infections in acute pancreatitis are associated with higher morbidity as well as mortality. I'll just look into the bugs that have been so far isolated in different groups. This is from All India Institute of Medical Sciences by Dr. Pramod Garg. Pancreatic pancreas 38%, extrapancreatic 31%. Most of infections were monomicrobial, polymicrobial only 32%. And most of the infections were by gram-negative bacteria, that was E. coli, Pseudomonas, and Klebsiella. This was from PGI Chandigarh in 2011. Pancreatic infections were seen in 37%, extrapancreatic in 62%. As regards the pancreatic infections were concerned, most of them were monomicrobial, whereas the extrapancreatic had an equal distribution of both mono and polymicrobial. Again, gram-negative bacteremia was the more common prevalent form of bacteria, including E. coli, Pseudomonas, Klebsiella, and the gram-positive was staph and enterococci. This is a recent study from Turkey, which shows that in pancreatic infections, they found a higher prevalence of polymicrobial infections. Now, this, I'm not sure whether it is because of pressure of antibiotics or the delay in doing the cultures or the multiple cultures that has been done. This is probably one of the few studies which showed a very high presence of polymicrobial infections in pancreatic infection. So, now, looking at the antibiotics that we can use. Now, one of the problems with acute pancreatitis compared to all other pancreas compared to other tissue is the resistance that the tissue provides to the penetration of the drug. Buechler in 1992 investigated 10 antibiotics and measured the tissue concentration and the tissue serum ratio. And the 10 antibiotics were mesdopenicillin, piperacillin, cefotaxime, ceftriaxone, netlimycin, tobramycin, ofloxacin, ciprofloxacin, imipenem, and metronidazole. And all these drugs were given 30 minutes before they proceeded with the laparotomy. And this was the dose given. And what it went on to show is that Aminoglycosides usually had a very low tissue concentration in the pancreas itself, and probably is not a good antibiotic of choice when you're trying to use empirically in these individuals. Meslocillin, piperacillin do reach adequate tissue concentration and adequate tissue serum ratio. Quinolones, ofloxacin, ciprofloxacin have adequate tissue concentration and a high tissue to serum ratio, and probably a very good choice of antibiotics. So is imipenem, celestine, and metronidazole. Subsequently, piperacillin tazobactam was investigated at a dose of 4.5 grams thrice daily, and showed to have a very good pancreatic penetration and good tissue concentration. Meropenem at a dose of 500 milligrams has shown to have sufficient activity against E. coli, Klebsiella, Enterobacter, and Proteus in the pancreatic tissue. However, the activity was low for Pseudomonas. So, in patients with suspected infections, what is the algorithm we follow? In patients with suspected infections, we start off with cultures, start off empiric broad spectrum antibiotics. Now, when I talk of empiric broad spectrum antibiotics, at our center, we usually start off with piperacillin tazobactam if the patient is hemodynamically stable. If the patient is hemodynamically unstable, we start off with carbapenems. And if culture is all the cultures, that is the blood, urine, if there are fluids like pleural or acidic fluids are negative, and there is clinical improvement, we continue with the antibiotics and wait on the patient. If there is no clinical improvement, we proceed with CT-guided FNA. And CT-guided FNA, what we try to do is access the retroperitoneal space. We try to avoid going into the space through a peritoneal approach. And at CT-guided FNA, if there's a negative stain or culture, we assume that it's probably a sterile necrosis. However, we continue with the antibiotics, and if necessary, repeat an FNA in 10 days if clinically indicated. If CT-guided FNA is positive, then titrate the antibiotics as per culture sensitivity. If the patient is clinically well, continue antibiotics. However, if the patient is clinically unstable, then we try to manage the patients so much as that we can consider an early drainage of the collections. Similarly, in culture positive patients, titrate as with antibiotics. If clinically well, continue antibiotics, but if clinically unstable, consider early drainage of the collections. Having said this, we do encounter a lot of drug-resistant organisms, and at this point of time, I think a role of infectious disease specialist in the management of acute pancreatitis becomes of paramount importance. Now, does antibiotics alone make any difference? Now, this is from the Dutch Acute Pancreatitis Study Group of 639 patients, a multi-center observational study, which showed that in the group of individuals who do not have organ failure, probably it is only in this group that only use of antibiotics alone may help. However, if there is organ failure, additional procedures either in the form of catheter drainage or laparotomy is required. So what about fungal infections? With the prolonged use of antibiotics, all of us are concerned there is a risk of fungal infections. Now, the mean incidence of fungal infections in the setting of pancreatitis is to the tune of 26%. Compared to patients without fungal infections, the in-hospital mortality is higher in patients with fungal infections. Length of hospital stay is higher in fungal infections. And amongst the patients with fungal infections, what has been found is that they have a higher rate of ICU admissions, and they have a history of use of prophylactic antibacterials, and they'll have a longer duration of antibacterial therapy. So the fungal infections increase mortality. So the question comes in, is there a role of adding antifungals to the antibiotics that have been instituted prophylactically? Multiple guidelines have commented that there is currently no recommendation for prophylactic antifungal therapy in acute pancreatitis. Now, coming to acute cholangitis, all of us know that the way to manage it is obviously start off antibiotics and institute early drainage. However, before we start antibiotics, we have to understand the setting at which the person has acquired this infection, whether the infection was acquired in the community or in the healthcare. Usually in the community, most of the bugs are usually non-drug resistant. However, in the healthcare setting, there's a high risk of drug-resistant organisms. And Patient-related risk factors is the other factor which we have to look in when you're choosing the antibiotics. That is age of the patient. If there's more than 70 years, they're high risk. If there are multiple comorbidities, they're high risk. If there is sepsis, they are at high risk. And if there's an immunocompromised state, they are at high risk. Now, the other condition which is of importance is the post-ERCV pancreatitis. We all heard Dr. Reddy talk about post-ERCV pancreatitis and the risk factors involved with post-ERCV pancreatitis, that is incomplete drainage, malignant hilar obstruction, sclerosing cholangitis, obstructed ducts, and immunosuppressed individuals. What is important here is that this is cholangitis which develops after the bile duct has been manipulated. And once it has been manipulated, there is always a risk of multi-drug resistant bug infections within the biliary system. And in our country, where many centers tend to reuse accessories for ERCP, this risk is much, much higher. Now, we had in our center looked at the microbial profile and antibiotic sensitivity pattern in patients with acute bacterial cholangitis. And what we found is that usually in acute cholangitis, the blood cultures do not give a very good yield. The yield is only around 26%, but bile cultures yield a very high rates of about 92%. But in the bile, more often than not, we get polymicrobial infection. And more common infections are usually, again, gram-negative organisms, that is E. coli, Klebsiella, and Pseudomonas. We looked at the sensitivity patterns, and E. coli and Klebsiella were usually found to be resistant to third-generation cephalosporins and ciprofloxacin, having intermediate sensitivity to piperacillin, tazobactam, amikacin, and etlimacin, and of course sensitive to imipenem. Pseudomonas had intermediate sensitivity to third-generation cephalosporin, ciprofloxacin, piperacillin, tazobactam, amikacin, and etlimacin, and was sensitive to imipenem. Enterococcus sensitive to teicoplanin and vancomycin, and intermediate sensitive to ampicillin. So as a choice of antibiotics, empiric antibiotics in community-acquired cholangitis, when there are no high-risk features, the antibiotic guidelines as determined by the infectious disease department of our hospital says that piperacillin tazobactam should be instituted at a dose of 4.8 grams Q8H, and the alternative antibiotic is cefoperazone sulbactam at 3 grams IV Q12H. In patients with high-risk features, ertapenem 1 gram IV once daily. In patients who develop cholangitis in the setting of a healthcare without high-risk features, again, piperacillin tazobactam or ertapenem, but in presence of high-risk features, initiate broad-spectrum antibiotic cover with the meropenem. Having discussed all this, I have stuck to only broad-spectrum antibiotics because beyond it, we all have to rely on the culture sensitivity report. And many a times at culture sensitivity, we get drug-resistant strains, and we have seen the emergence of drug-resistant strains. Now, this is a recent study, not recent, as in 2019 study, which looked at the global epidemiology of infections in cirrhosis, different disease, but closely related to gastroenterology. And here we can see that in India, there's a high prevalence of multi-drug resistant bugs. And this is primarily because of antibiotics exposure and prior health exposure. And in our hospital settings, the patients are very close to each other, and cirrhotic patients are next to acute pancreatitis and IBD patients, there's always a risk of cross-transmission of these infections between patients. And therefore, it is imperative that we practice the 5 steps of hand hygiene as healthcare practitioners when we move between patients. To summarize, infection in GI need multidisciplinary team input, including the GI physician, intensivist, ID specialist, and surgeons. Thank you for your patient hearing.
Thank you, Dr. Sudipta. Now the presentation is open for discussion. Any question, comments, or anybody would like to say? Because, one thing is, going through all the slides and so on, and second is practical. Let me ask you, because you are the practicing gastroenterologist, I am an internist. A person who comes to you with acute severe pancreatitis is running fever. How many of you in this hall would not give antibiotics? Just raise the hands. You'll not give antibiotics? All right, okay. That's a very heartening thing to note. Yes, it's a very encouraging sign.
Can I know the poll results, sir?
People are courageous. Yes, the result says that most of them would not give it, which is a very encouraging sign. And I believe that that's being practiced.
Of course, that depends upon the time that the patient has.
No, it's fine. What I'm saying is at the time of presentation, if it comes within 48 hours, the real time when there is the main issue. Because in India, fever is taken as a sign of infection.
Dr. Chaudhary, I think our residents would benefit by understanding what is exactly prophylactic antibiotics. I mean, one is of course a patient who has fever and all, and you use antibiotics in that. But the concept of prophylactic antibiotics is not entirely clear to many people.
I think the concept of prophylactic antibiotics we have to look at in the setting of acute pancreatitis. When you're talking of acute pancreatitis, is most of the trials which have looked at the use of prophylactic antibiotics have been using antibiotics within 48 to 72 hours of hospitalization, irrespective of the clinical scenario that the patient is in. Now, when I talk of this, if you look at the Cochrane meta-analysis, it is a subcomment of all the studies that have been included. The interesting thing is that in those studies, they were pretty old studies, of course. Most of the studies which had looked at prophylactic antibiotics and randomized control trials, the group of patients who were admitted directly to the ICUs were excluded from the studies because those patients were in the ICUs, they were was always a protocol to give antibiotics to this group of patients who are critically ill. So as a result, there was a caveat in those in that meta-analysis that we cannot comment on patients who are critically ill and going into the ICUs whether prophylactic antibiotics would benefit, because ICUs as a policy, whoever goes into ICU as immediate admission may be put on antibiotics. That was very old concept.
Yeah, before we go to the floor, I think we have some questions from our online residents. So there's Dr. Shrikant Gopi from AIMS. He wants to know whether there is any data on use of lavage, antibiotic lavage in patients who have walled off necrosis.
It has been tried and not shown to have very significant benefit. There have been a few studies, very small number of patients have used both gentamicin and has shown a marginal benefit, but the quality of studies were very poor. If I remember correctly, there has been at least one study which I don't remember the name of the study, but I do remember the antibiotic. And there have been a few studies which that, but the quality of studies were very poor. And most of us do not use antibiotic lavage in the pancreatic collection itself.
Professor Usha Dutta.
I just have a question for you, Dr. Chaudhary. Lot of the study which has been often quoted that these antibiotics penetrate the pancreas and these don't, they have been done on normal pancreatic tissue during surgery. But here we are talking of an infected necrosis. So these are under-perfused pancreas. So do these antibiotics reach such kind of places? Have anybody done studies on pigtails and seen whether the output of the pigtail carries the antibiotic or not?
Yes. So the two studies that I had mentioned, the three studies I had mentioned in my thing, including Buchler study and the other two studies, were done on human tissue. Now, all these patients were taken up for pancreatic surgeries and lavage of the pancreas. The last two studies, which was Ondo studies and the other one, both those studies were done in acute pancreatitis scenarios, and they measured the not only the necrotic material, but also the pancreatic fluid. And they measured it using HPLC.
And do they have any studies on pigtail drains, which we put in these patients? The output of that, have they studied that?
Whether the antibiotic sensitivity or you're talking about penetration within the pigtail drains itself, I'm not sure about that now.
Okay, thank you.
Dr. Sachin?
Sir, two questions actually. First is a patient with severe acute pancreatitis, day 5 or day 6 with multiple organ failures. Would you, and SIRS of course, would you start antibiotics? And if yes, why? And question number 2 would be a patient who is into his 3rd week of pancreatitis, has received multiple antibiotics, and we have cultures and we do not have any positive fungal culture. Again, would you start antifungals? If yes, why? If no, why?
So coming to the first question, you said about day 5. So day 5 is a period when we actually do not have real justification for starting antibiotics because as I had shown you on the study from the Dutch acute pancreatitis group, which they showed very clearly that the earliest median period at which infection actually sets in is between day 8 to day 10. So yeah, I know it's just a matter of semantics whether we call day 5 or day 8. The idea is to delay antibiotics as much as practicable. But yeah, we would not start antibiotics within the first week of illness of an individual. Coming to your second question about a patient receiving multiple antibiotics and having high spiking fevers, if there are no cultures for fungus, we do not recommend use of prophylactic antifungal or any antifungal medication in those individuals. Because what antifungals can we use? We are talking of anidulafungin or caspofungin. We are not talking about fluconazole here. And in these patients who have a renal failure, we are not talking of amphotericin either. So, and both these drugs, one, come with costs. Number two, they are extremely expensive. And the second thing is that, we have to justify its use because we do not have any fungal culture. And there's not necessarily that the patient is not improving because of fungal culture. Important thing is that when you suspect fungal culture is to ask the microbiology team in your hospital to wait for the fungal culture or culture it for fungus. Because sometimes after 48 hours, you may not have a culture report, but you have to wait on it for it to grow.
I'd just like to add, and maybe try to modify the statement. The patient is talking has got a multi-organ failure. Now, it becomes extremely difficult to define whether this organ failure is because of pancreatitis or some superimposed infection. Please remember that there is always a caveat in infectious disease that the whole thing is dependent on culture positivity. But please remember, culture positivity is never 100%. Never, never, never. You have to resort to molecular studies. Unfortunately, these type of studies are not there. So I would, that's where the experience counts. Whatever you may say, whether to give it or not to give it, there will be pros and cons of both. Definitely, if the person has got shock, I would err on the side of giving it. Barring that, yes, you're right in the sense that if there are no organ failures, just running fever, severe pancreatitis, you can hold on. No issues about it. But if the person is in shock, I would always give antibiotics after IV fluid resuscitation. If the blood pressure doesn't come up, because the commonest cause would be fluid deprivation. You give fluids, blood pressure is stabilized, fine. Person is in shock. That's my personal take. And finally, it comes down to what you do, how best results you get, and these questions definitely cannot be said as yes or no. I think the watertight compartments cannot be justified. Yes, but you have to say something about it.
No, not about this, about something else. If I can get back to what you said about the flow chart about management of pancreatico biliary infections. I feel on the left side of the chart, you had culture negativity followed by patient who is stable and is improving actually, and you wrote that the patient should be continued with antibiotics. This seems to go against all the practices of antimicrobial stewardship practices. How do you justify this?
Yes, sir. We started, I put this slide up, and mind if I just again reshare that slide if you would like to have a look at it again. This is after we've already initiated broad spectrum antibiotics, sir.
Yeah, I agree. But once the patient is stable,
person has suspected infection with persistent SIRS, having rising counts, elevated procal CRP, and cultures are negative still. But with broad spectrum antibiotics, there's clinical improvement. We would err on the side of continuing that antibiotic.
And that has been the reason for MDR infections all over the world, everywhere, in every system. Once the patient starts to improve, your markers have gone down. Infection. Why would you want to continue? You are basically selecting for MDR organisms.
No, I think I think that there's a thing which is lost in translation here. What I wanted to say here is, when there is clinical improvement, we continue antibiotic for the duration of the antibiotics, not continue it indefinitely.
There is no scheduled period of antibiotic therapy anymore.
No, but
I think the discussion can go on and on.
For
Yes,
example,
I think with this, there is lots of things which we have to think about, possibly get onto consensus, because Indian settings are going to be different. As you can see, all these things are done from Western, where ICUs are absolutely clean, because don't look at the patient, look at the environment. Right now, the place where I'm sitting, I can see 4 or 5 mosquitoes, 10 or 12 houseflies. So you can understand the things are going to be a little different in India. So what I suggest is that if you have an Indian consensus guidelines based on the evidence plus the experience, and come out with some guidelines, because these things would be a little bit individualized. Yes, and with this, thank you all for active participation, and we hand over the mic to the organizers. Thank you very much.
thank you.
Thank you, chairpersons. With this, we come to the close of the day. Tomorrow, we have 4 brilliant sessions followed by a quiz. We start off at